CPR. CPR stands for Cardiopulmonary Resuscitation. It is one of the major and most basic step that has to be performed in the basic life support or any life support as such. CPR, the actual mechanism is understood in a way that when a person's last heartbeat, that is the last heartbeat that stops, that time there will be a pressure gradient that is created. That means that here the aortic pressure and right atrial pressure difference will be there. Similarly, there will be left atrium and pulmonary circulation pressure difference will be there, and because of this there will be forward propulsion of the blood, and this occurs for those 5 minutes. So basically I mean to say that the cardiac activity, even though it has stopped, but for the next 5 minutes there will be still a circulation that will be present because of this pressure gradient difference, and until the pressure equalizes to in all the chambers. Now coming to the CPR, it actually follows this principle that in the initial step itself we have to maintain that flow of blood. So CPR has to be a high quality CPR whenever we are giving. So what does it mean? That it should be push hard and push fast. So in the BLS, we go with the normal steps of going with the scene safety, and then calling for the emergency, and looking, tapping the patient, and seeing whether pulse or breathing is present or not. If breathing is abnormal, pulse is present, and observing the patient. And once we find out that the pulse is absent and even the breathing is absent, immediately we have to initiate the CPR. So as I mentioned, it should be a high quality CPR. So the process of how you do it is you have to interlock the fingers, and with the heel of the palm you have to press in the lower 1/3 of the sternum. You have to sit beside the patient, to make to be more comfortable, and you have to push it in a way that the force is not coming from the bending of the elbow but from the sternum, from the shoulder girdle. When you are pushing it, it should not arise from the elbow, it should arise from the shoulder girdle, so that effective pressure and squeezing effect is there. So when you're pushing it that way, the myocardium, that is present, the heart which is present between the sternum and the vertebral column, because of the pressure it gets squeezed between these two, and there is a pumping, there's forward propulsion of the blood that occurs in the blood vessel column. So the normal protocol is 30:2 compressions, that is 30 compressions with 2 breaths, or we can say that there should be, but ideally it should be 120 beats per minute, with breathing every 6 seconds. So that way it is more effective, and try not to have more of the interruptions, and allow proper recoil, because we need to fill that ventricles in order to push the blood and make it a systemic circulation. Now coming to the CPR has to be done for 20 minutes, with in between activation of the automated electrical defibrillator. So automated electrical defibrillator is used to assess whether an individual has a shockable or a non-shockable rhythm. A shockable are like the paroxysmal ventricular tachycardia or ventricular fibrillation. So if you find the rhythms which is being saying that it's a shockable rhythm, we have to immediately start with charging and giving the defibrillate the heart, and again continuing with the CPR. So this has to be alternatively done until the person revives. If in case it is a non-shockable, which means pulseless electrical activity or asystole, then immediately we have to load the epinephrine, 1 gram IV, and we have to give, and every 4 to 5 minutes we have to repeat with alternating with the CPR. And we have to also start with antiarrhythmic drugs like amiodarone or procainamide. So these are the drugs that can be started along with doing the CPR. And coming to the and we have to keep on assessing the vitals at the same time, And once the patient the has revived, we have to immediately connect him to we have to keep on oxygenating the patient at the same time. Yes, we have to keep on oxygenating the patient at the same time. And there are various causes, the reversible causes that has to be looked for, and we have to target those underlying reversible causes. They can be hypoxia, metabolic causes like metabolic acidosis or hypokalemia, and there might be hypothermia, or there might be coronary or pulmonary thrombosis, cardiac tamponade, or due to certain toxins. These are certain conditions which can be reversed, and as soon as they are being diagnosed with certain reversible condition, they have to be treated for the same, and observation has to be done in the ICU until the patient's vitals are being normalized.